Alright, for this MPJE video, we are basically going to discuss the laws and regulations, which make up about 3% of the exam, but they do, from what I understand, incorporate this into multiple questions sometimes, and, well, it could be more than 3% in my opinion, because there's so much information here. And these are probably going to be the easier questions, so you definitely want to get these right. So we'll just jump in, and of course, to start about this, we're going to basically do a background of your law. And this is probably going to be a two-part video, but the Federal Food, Drug, and Cosmetic Act, the FDCA, which is your main act. They're talking about everything after it is pretty much an amendment, except for like your Poison Prevention Act. And there's a few things that came before it, but the Federal Drug and Cosmetic Act is our first big one, as it distinguished between all of these things: foods, drugs, cosmetics. So of course you understand what a food is, but your drugs have to be recognized in the official U.S. Pharmacopedia, USP&F. It had to meet standards of strength and quality and purity. And this is pretty much the whole act with the amendments. So articles other than food intended to affect the structure of any function of the body of humans or animals. Drugs even included, counterfeit drugs. So for cosmetics, pretty much if it's applied to the human body for cleansing, beautifying, promoting attractiveness, altering appearance, it's a cosmetic. And it does not include soap because that already existed. And it also defined devices, which is recognized in the National Formulary. They can be used to diagnose. They do not achieve their principal purposes through chemical action in the body. And there's 3 classes of those which were defined in an amendment. Class 1, the lowest risk, like something like scissors. Class 2, like heating pads have more of a, could hurt you. And Class 3 is your highest risk, which is like heart valves. They require that pre-market approval. Now, so with the FDCA, it was the first to say that drugs had to be proven safe for their intended use prior to being marketed and sold. And then now it says safe and effective was an amendment that we'll mention. It also defined your adulteration and misbranding. Adulteration deals with the contents of the product, misbranding deals with the written information. So adulteration's the inside, misbranding's the outside kind of thing. Outside as in the labels, not the drug. Even the advertising, that's all under misbranding. So your agency with primary enforcement of the FDCA is the Food and Drug Administration. The FDA is an administrative agency with rule-making authority, even though it does take forever. But this includes your Center for Biologics Evaluation and Research, Center for Food Safety and Applied Nutrition, Center for Drug Evaluation and Research, Veterinary Medicine, and Center for Devices and Radiological Health. So let's talk about leading to the FDCA. Your first major act was the Pure Food and Drug Act, which is your labeling act that required labels. This act only prohibited adulteration and misbranding, so it didn't necessarily define them, but they were like, no false or misleading advertising. This is 1906. So before that, who really knows what they did? People just made drugs and made claims. So the act amended to prohibit false and fraudulent claims. And then the sulfonamide elixir, which was 107 deaths reported. So that led to drugs having to be safe, your FDCA. So, and it also defined adulteration and misbranding. Drugs had to be proven safe with the FDCA. They had to add warnings for habit-forming drugs, adequate directions of use, and any drugs before this were exempt. You also had to list ingredients on your label. FDA given authority to inspect manufacturers and distributors. And then pretty much everything after this is going to be amendments. There was the Lanham Trademark Act, which prohibited the use of any false description or representation, including words or symbols, in connection with the sale of any goods or services. So your first amendment is your Durham-Humphrey Amendment. This was the Prescription Drug Amendment. You probably will have a question on this. Humphrey was the vice president of the U.S., and from my understanding, he was a pharmacist. So that is a easy way to remember that, or just like know this act. It was 1951, but it distinguished between prescription and OTC. So prescription drugs, legend drugs, had to have the statement, "Caution, federal law prohibits dispensing without a prescription," which is now RX only is the actual quote, so they can actually have both of those nowadays. Prescriptions are unsafe for use unless under supervision of a practitioner. So their habit forming, their ADR risk is high, things like that. So prescriptions are authorized written and oral prescriptions with prescription refills. Electronic did not exist yet. And mandated pharmacy record keeping. And for OTC, drugs that are safe and effective or safe medication by the consumer. So distinguish these two classes is our main thing here. Also added adequate directions for use, which contain directions which a layperson can understand, quantity for dosing, frequency of administration and application, duration of treatment, time, route, administration, preparation, and adequate information for use. Your next amendment came with the Food Additive Amendment. Then there was the Color Additive Amendment. And then something that you're probably more likely to be tested on is the Keflar-Harris Drug Efficacy Amendment. So it's the first law that required drugs to be effective. It was results of the some birth defects with thiodolamide, and it gave the FDA more jurisdictions here. And well, I guess that's it. Pretty much safe. Now drugs had to be both safe and effective. And this is an amendment to the FDCA. Made the FDCA stronger, and even made the FDA stronger. So your poison prevention packaging that came next, your PPA, and I have a great FAQ video on that. I would check that out. It's bound to be 2 or 3 questions. But so it's not part of the FDCA, but any substance that is customarily produced for or used in the household and is designed as food, drugs, and cosmetics now had to go with this Poison Prevention Act. The Consumer Product Safety Commission has the responsibility of enforcement of the PPA. It requires child-resistant containers, so 80% of children under the age of 5 should not be able to open the container, whereas at least 90% of adults can open the container. And of course, you can get a waiver for this. Prescribers can only do it once, but a patient can make a request to like a blanket waiver for all of their medications. It doesn't have to be documented, but obviously that's very encouraged. Your exceptions: your manufacturer can produce one size of OTC product for elderly or handicap, must contain the warnings, like Tylenol arthritis with the red cap is a good example, and your oral disintegrating aspirin for emergency use, your sublingual nitroglycerins, your OCs, oral contraceptions. And 1972, there was the Drug Listing Act. This gave the NDCs, the National Drug Codes. So it's on all OTCs, prescription packages, and inserts. It's 10 digits, 3 segments. The first is going to be your labor code, so your via the FDA, your manufacturers, who made it. Second is the product code, going to tell you about the drug, and that's 3 to 4 digits in the middle, and the third, and these are all separated by hyphens, but the third is your package code, 1 to 2 digits, and it's going to tell you, how many are in this package. Basically, 01 could mean it's a 100 tablet package, things like that, but it's going to be the same drug. The last 2 digits if the last 2 digits of an NDC code are different, it's still the same drug in there, just the package is different. Next came your Medical Device Amendment. And that kind of gave the classes I talked about. Made some good marketing practices. But more importantly, next, and we're in 1982 right now, your Product Tampering and Federal Anti-Tampering Act came about. So it was a result from the Tylenol murder, established requirements for tampering-resistant packages. And this is for OTC products. So obviously your prescriptions are going to be exempt from having the anti-tampering. And other exempt include your dermatologics, your Durfisine, your insulin, and your lozenges product. I imagine you see a lot of insulin lozenges choices, and those are going to be exempt from the tampering. It also established requirements for the tamper-resisting practice or packaging, It has to be very obvious, and when a consumer opens it, if the tamper is gone. You know, they never call it the Tylenol murder. Anyway, there's your Orphan Drug Act. So to apply for this, you know, it gives you like exclusivity. I believe it's 7 years. You have this patent or this license incentive, and you have tax incentives. So it makes the drug process cheaper and makes it where you can probably profit off of the orphan drugs. You know, these drugs that people aren't making because there's no profit from it. So to qualify, the drug you're making has to be for people with a disease that's less than 200,000 people, or you have to have reasonable expectation that the drug will not make as much as it costs, not make up for how much the drug costs to apply for these incentives. Next came your Drug Price Competition and Patent Term Restoration Act. So this is the Waxman-Hatch Amendment. They did establish the Orange Book. It made the abbreviated new drug application for generics. So it streamlined the generic approval process. So now when you're making a generic, manufacturer makes generics, they use the ANDA. That point out that states have a voice on how and when they can substitute generics. For example, in Alabama, you can pretty much substitute unless the prescriber says not to. Your drug efficacy study implementation came about. Your Prescription Drug Marketing Act came. That one's a little more important. So it amended the FDCA, had a big impact on drug samples. So there's more accountability for drug samples here. Changed how drug companies and drug reps operate. So prescription drug samples, typically a unit of a drug intended not to be sold, but rather to promote the sale of the drug. Prescription Drug Marketing Act prohibits the sale, purchase, or trade of samples. Now, starter packs are not considered samples. And in order to get a sample, and this is probably the most important aspect here because it's easiest to write a question about, but a prescriber has to have a written request for the samples to get them for Prescription Drug Marketing Act. Hospital pharmacies may receive samples at written request of licensed practitioner, provided the receipt contains what's entitled. You know, person acknowledging delivery, entity designed to receive the drug, name, strength, quantity, lot number, things like that. Resale of the drugs by the hospital is illegal. There are record-keeping requirements. Now, you cannot buy prescriptions in other countries and bring to the U.S. under this Prescription Drug Marketing Act, so there's no importation, unless, and the exceptions here would be less than 3 months supply for a patient. So there's no exception on the quantity you can bring, but it has to be for personal use, and it has to be less than 3 months supply. So if you take something 4 times a day, you know, or 10 times a day, which isn't a thing, but you could actually do that. It just has to be less than 3 months supply for you. If it's not available in the U.S., and you have no intent to sell, the FDA cannot search you routinely, only if they have suspicion of you. Something to mention, if that something doesn't have a med guide, it's going to be misbranding. Dietary supplements are under foods, and that includes vitamin, minerals, herbs, amino acids, L-lysines, and any of their concentrations or extracts. These can be in combo, but pretty much it's not a food. Dietary supplement isn't a food if it's replacement for the conventional food, or if it's the sole item of a meal or a diet. It's no longer a dietary supplement. So another note I have here is that package inserts have information for a healthcare provider. Next was your Safe Medical Devices Act, 1990. We're in the 90s now. Gave the FDA more authority, really. That one's pretty relevant, but the Omnibus Budget Reconciliation Act, OPRA, the OBRA. So patients must be counseled now. Drug utilization review is pretty much a thing. Starting in 1990, there's informed decision. Patients have to have an informed decision to improve the quality of care and reduce medical costs. Pharmacists must now perform prospective drug utilization reviews. and counsel all Medicaid patients. So in Alabama, specifically, you do counsel every patient, but your drug utilization review looks for therapeutic duplications, drug interactions, contraindications, incorrect dose or durations, allergies, drug abuse or misuse. It also gave pharmacies started getting background demographics, age, allergies, gender, things like that. Also 1990 was your Nutrition Labeling and Education Act, NLEA. So mandated nutritional labeling on food. Then there was the Generic Drug Enforcement Act, since the FDA was accepting bribes. So now, if you can't participate in the approval process if convicted of a related felony about bribes. That was 92. There was the Prescription Drug User Act, PDUFA. So the industry had to pay significant fees. There was the Dietary Supplement Health and Education Act, the DSHEA. This didn't include tobacco, but it's everything I kind of talked about in my notes. The dietary supplements count as food. If it's a sole item of a meal or diet, it's not a supplement, it becomes a drug. They are now allowed to make claims here. They weren't before. So now they can say, this drug or this dietary supplement will help you sleep. It's heart healthy, like Cheerios or something. But if it says it's a disease-associated statement, like improves diabetes or things like that, it becomes a drug. So, but this made the dietary supplements treated more like a special food than a drug. There's no pre-marketing approval needed, which is a little concerning. It must include, this statement has not been evaluated by the Food and Drug Administration. This product is not intended to diagnose, treat, cure, or prevent any disease. The FDA can only take a supplement off the market on the basis of public safety. So next is your Food and Drug Administration Modernization Act, FDA-MA, 1997. Streamline your processes, required FDA to define the scope. Expanded their authority over the OTCs. And then we're in the 2000s. You have your Electronic Signature and Global and National Commerce Act. So now they can e-sign. Food and Drug Administration Amendment Act, increased authority for FDA. Patient Protection, Affordability and Care Act, your Affordable Care Act, Obamacare. The FDA Safety and Innovation Act, FDA SIA, which was just kind of reauthorizing the older amendments. But more importantly, you have your Drug Quality and Security Act, DQSA. This was the Compounding Quality Act. And it resulted from the New England compounding case where there's a meningitis outbreak from the compounding manufacturer. So this required general pharmacies to pretty much register as a 503A for use in compounding. They don't have to, they're exempt from the good manufacturing practice. But if you do a lot of outsourcing, basically more than 5%, I think that's the thing here. But if you do a lot of outsourcing, you become a 503B. 5% of your controls, sorry. But 503B outsourcing facility on a federal level. Sorry, that 5% thing's not here in this. I'm getting confused. But 503A is a general pharmacy. It's like CVS, Walgreens, 503B is an outsourcing facility. So they compound. They have good manufacturing practices they abide by. And they sell it to other pharmacies or places. So on a federal level, additional rules and regulations were issued by the state boards of pharmacy. Most of them kind of just copied that, but it strengthened the FDA oversight on compounding. And you should check out my compounding videos. It talks about 503B a lot, and they have some general guidances that I read over and highlighted. So your Drug Supply Chain and Security Act, DSCSA, 2013. Pretty much started the track and trace. For drugs, certain data must be maintained. Part of electronic software needs to exist and verify records. And 2015, we did get the new pregnancy. A, B, C, D, and X were phased out. Now the new sections are, female, male reproductive potential, pregnancy, lactation. There also was CARA in 2016, some new C2 partial fills, like if a partial fill of a C2 is requested by a practitioner or a patient, they actually have 30 days instead of 72 hours. So I suppose a scenario where 72 hours would be relevant is if the pharmacist wants to partial refill because they only have a certain amount of the C2, they have 72 hours. I think that's a confusing thing. I don't think they would test you on that, but we'll have to see. All right, next video will pretty much be along this about regulations, and I'll post that one soon. Thanks. Good luck.